I'm Dr. Laura Swoboda, family nurse practitioner, wound care coordinator, and professor of translational science. Thank you for joining me for this lecture on empowering ourselves to achieve more and how to kickstart the healing in acute and chronic wounds. This lecture is on Endoform. I am a consultant for Aroa Biosurgery. And today we're going to be talking about the Aroa extracellular matrix and what that is and how it works and how you can use it within your practice to really expedite healing outcomes and increase access to advanced wound care for your patients. Aroa's extracellular matrix is from New Zealand, so you can see country over there on the left there, and it's made out of an ovine forestomach, so that's a sheep stomach. And New Zealand has a high amount of sheep there. The highest ratio peaked around 22 sheep to every one person. So they found, there was a veterinarian who was researching and found that this ovine forestomach could be used in acute and chronic wounds to expedite the healing process. So looking at the forestomach of that sheep, we can see, this is an area with high cell turnover. It has a less caustic environment than the other portions of the stomach for the sheep. It's highly vascular, so there's these vascular channels running within the product. And again, that high rate of tissue turnover, the remodeling, and that's really important for what's inside of this extracellular matrix, which we'll talk about in a little bit. So why do I use the Aroa extracellular matrix? This is an advanced extracellular matrix. It provides a balance for the wound bed. So looking at this photo over on the right, we can see a wound progressing into almost two different portions of wound healing. We're getting some granulation tissue over on the left there, but then towards the bottom, we have slough. It's more inflamed because of that bioburden. And then across the top, we can see exposed structures. We can see some tendons and possibly some ligaments that are exposed. So Endoform is a product that would be appropriate for that entire wound. And as we can see, in just 15 weeks with using this product, that wound with multiple areas of inflammation, with exposed structures, was able to go on to closure. And that's because of what's contained within this extracellular matrix. So the Aroa ECM is angioconductive, and when you hold the product up to light, you can actually see those vascular channels within the product, and that facilitates rapid blood vessel formation. Looking at that photo on the left there, that's a dye stain of the product of the extracellular matrix, and it shows you those residual vascular channels within it. And then over on the right, we can see newly formed human tissue, so new formed blood vessels, and how similar those layouts are. So the extracellular matrix has these channels that our body can use as a template to build new blood vessels. Now, looking at the product, the Aroa ECM Endoform, compared to reconstituted collagen, when you're looking under a scanning electron micrograph, we can see the extracellular matrix of the Aroa ECM. So this is well organized. It looks very similar to our tissue, to human tissue. It has structure, it has more components than just an empty scaffold, as opposed to reconstituted collagen, which is disorganized. It's held together by some cellulose fibers, some chemically modified cellulose fibers. So this is not as similar of a structure as our tissue. What's important about the Aroa ECM is that it's not just an empty scaffold for our cells to grow along into. Within that scaffold, there's over 150 different extracellular matrix proteins. So those are things like cytokines, chemokines, growth factors, all of the extra goodies that help to promote wound healing, in addition to the collagen that we're getting in the matrix. In addition to that, the Aroa ECM is minimally processed. So it's very gently processed to decellularize it, but it still maintains that shape. So looking at how that extracellular matrix can help to promote tissue growth, it promotes really organized tissue formation. Here's a case where we have a full thickness ulcer, and we can see with applying that regularly how we're getting new blood vessel ingrowth, that angioconduction, how the extracellular matrix is undergoing remodeling. It's helping the tissue to contract in and grow. And what we're getting is a really vascular, organized tissue and a healthy, robust scar. So what is an extracellular matrix and why do we use it? Why do we donate that to the wound bed? Well, that's because evidence has shown that this is going to expedite the wound healing process. This goes over what we talked about before, how this is more than just a scaffold of protein. There are over 150 different proteins and molecules that are going to help with wound healing within this extracellular matrix. So this is much more than collagen. You're getting, yes, the type 1, the type 3, the type 4 collagen that provide the strength and the architecture of the matrix, but you're also getting fibronectin, you're getting hyaluronic acid, and all of these other important components that are helping people heal. So that is what is contained within Endoform, this restorative bioscaffold. And we can see, you know, that little circle on the right there, we can see the extracellular matrix with the molecules, the extra components, and then the angioconduction, those residual vascular channels within the product. I really like this because it demonstrates that you're getting so much from this product. So this product is an A code, right? It's reimbursed. You use it as a dressing, but you're getting so much more than a dressing. So when you're looking at a collagen dressing, you're only getting collagen. Sometimes you're getting some cellulose, some calcium alginate, that type of thing within it. And it also tends to be bovine collagen. So that's a beef tendon or hide within the collagen. So there are a lot of cultural considerations where patients may not be able to use a beef product, as opposed to Endoform, where we're getting collagen, but we're also getting all of those other components, and it's still an A code. And when we look at a Q code, those are our cellular and tissue-based products. Those are very, very expensive. And there's a lot of limitations for use. We have insurance limitations, we have copay limitations, we have wound size limitations. So in the outpatient environment, if a wound is over a certain size, we can't use cellular tissue products because we can't buy a big enough piece. But for a product like Endoform, we can use the appropriately sized product for various wound sizes. So you're getting all of those important components that are in a lot of Q code products with the benefit of being able to use it as a dressing. In addition, you don't have to be a provider to apply this product. This can be used from day one, and people can be applying it in across environments. We could order it for the home, etc. So looking at kind of the product portfolio, we have Endoform Antimicrobial that has ionic silver in it. And then we also have Endoform Natural. And they come in kind of two different main versions. We have the high flow, and you can see the fenestration shape in the high flow is more of that U shape, and that's letting the exudate get through the product. So you can use it even when patients have a larger volume of exudate because it's going to transfer through the product. There's also a fenestrated version, which has a little bit different of a cut into it, and that's for a lower to moderate exuding wound. Endoform is a product where you can use it on almost every wound type. So we use it for the management of acute and chronic wounds. And just look at all these wound types that are listed. We have pressure ulcers, all of our main ones, pressure, venous, diabetic, many atypical wounds we can use this with as well. You can cut it, it's easy to use, you cut it to shape. So you can tuck it into tunneled and undermined areas. You can stack multiple layers of it. So it's extremely versatile as well. Thinking back to that photo that I showed where we saw that foot ulcer with granulation tissue, with slough tissue, with exposed structures, that really exemplifies how endoform can be used during all phases of wound healing. So we have hemostasis. So we can use that, right after a debridement, that type of a thing. During our hemostatic process, apply some pressure over the top of it. It works very well. It works extremely well in the inflammatory phase. So this is a collagen. It's working as that sacrificial substrate, but it's also modulating the proteases within the inflammation to decrease that inflammation and allow the wound to progress to the proliferative phase. And it's also helping the wound in that proliferative phase because it's functioning as that extracellular matrix, helping to guide angioconduction, helping to guide the cells proliferating. And then, of course, remodeling. So when we get a robust granulation tissue and we have that good structure to our healing tissue, we're going to have a better remodeling phase because we have better organized tissue going in. So here's another case where we're looking at a foot ulcer, and we can see this was with Endoform Natural. This was a diabetic foot ulcer, and it healed in 3 weeks. We can see the initial wound size quite large here, and here that wound is epithelialized. So again, this extracellular matrix is able to be used from day one. This is something where you see the patient, you perform really thorough wound bed preparation, cleansing, non-cytotoxic cleansers, debridement, and then we can apply this product and know that it's going to help the wound heal up faster. What we know is that this product can help to modulate proteases, modulate inflammation. So chronic wounds, we know, become stalled typically in that inflammatory phase. Inflammation is a hallmark of hard to heal, stalled chronic wounds. They often fail to pass out of that inflammatory phase because of these proteases, these enzymes that are pro-inflammatory, that are eating the patient's extracellular matrix, preventing the wound tissue from growing. So what this product does is break that cycle. It modulates those proteases. It decreases the bioburden. It also helps to limit biofilm reformation. So when you're prepping the wound bed, when you're removing the biofilm, this product will help limit its reformation so that the wound can continue to heal without having to chronically fight that biofilm. And looking at the idea of being able to actually modulate proteases, so it doesn't just sequester them like a collagen where it's holding them away, it's giving them something to chew on. This actually changes the expression of them, right? It's modulating those proteases. So we can see how Endoform is compared to a collagen with ORC and how Endoform is modulating all of those matrix metalloproteinases that we associate with delayed wound healing. The collagenases, and then the MMP3, 10, 12, 13, and 14. And look at that huge difference in the ability to decrease the expression of those proteases compared to the collagen with ORC. Now looking at, do I want to be using Endoform Natural or do I want to be using Endoform Antimicrobial? It's important to consider, what is within Endoform Antimicrobial and why I would want to be using that. Now, It has 0.3% ionic silver within it. Ionic is a very safe but bioavailable silver. It has long lasting and very broad spectrum antimicrobial activity. Again, it's been studied, and this actually limits the biofilm formation. And most importantly to me is this is non-cytotoxic to dermal cells. So as we age, we accumulate pharmaceuticals that are prescribed, and we accumulate comorbidities that are all associated with delayed wound healing. So we don't want to be using anything cytotoxic for our patients that's going to further delay the wound healing cascade. Using endoform antimicrobial where a wound is susceptible to infection. So for me, that's almost all of my patients, right? Certainly, a diabetic foot ulcer, heavily inflamed, patients with other risk factors. And here we can see again that diabetic foot ulcer with a time to closure of 9 weeks. The ionic silver within the dressing can help protect it from bacterial invasion and limit that bioburden within the wound bed. So when we're looking at it preventing biofilm formation, this is again something that they've actually studied, and we can see endoform antimicrobial compared to collagen ORC, compared to a collagen silver, and then compared to just gauze and the biofilm formation after applying the product. And we can see how successful endoform antimicrobial was at limiting the reformation of biofilm. So we know that biofilm is associated with delayed wound healing. It's associated with an increased risk of infection. So it is something that we want to limit and address, and biofilm-based wound management is a core concept in delivering good wound care. So using this product as part of our wound bed preparation and treatment is a way of delivering that biofilm-based wound management. Now, another important consideration for me is that endoform antimicrobial is non-cytotoxic. There are absolutely silver products that are cytotoxic. They can damage DNA, and they're, something that I try to avoid when I'm thinking about what I want to be using for patients. So this really shows you endoform antimicrobial as opposed to endoform natural. And then it compares it to collagen ORC, and they apply the dressing to some dermal fibroblasts, and then they're looking and seeing, are those human fibroblasts still viable? So when they've looked at the endoform, they can see, 100% viability using endoform natural. Those fibroblasts are still viable. When they look at the endoform antimicrobial, they can see we still have a really high percentage of viability. We have, over 90% of those fibroblasts are still viable. But after the collagen ORC with silver, we can see that the percentage of cell viability is extremely low by comparison. So we're looking at, much less than 10% cell viability. So when patients have comorbidities, they have diabetes with, hyperglycemia, things that are already going to impact their fibroblast activity. I don't want to be using anything else that's going to be cytotoxic, that's going to slow them down any further. Silver is typically associated with some cell toxicity, like I talked about. So knowing that endoform antimicrobial is non-cytotoxic is a good reason to support its use. Endoform is really, really versatile. It can be used with a lot of advanced therapies. I like to stack advanced therapies. I use, multiple interventions at the same time. So this is something that I use under negative pressure wound therapy. You can use it under traditional and disposable or single use negative pressure wound therapy. It's safe to go in hyperbaric oxygen. You can absolutely use it under compression, and you could use it under total contact cast. So we can use it with all of our advanced therapies. Now, when you apply endoform, it's normal to see some residual endoform. So when you apply the product, if the wound has a heavy amount of bioburden of inflammation, it's possible that those proteases are going to essentially chew up the graft, and that you're going to end up not seeing any product when you're removing the dressing at follow-up. And that means that you can probably add a layer or two when you're applying it to give the proteases something else to work with. But as the wound transitions and as the product is effective in the wound bed, you're going to have the potential to see some residual endoform in the wound. And that's normal, and that is something that could actually be left in place. So as I said, when you see that residual endoform, that's a visual guide that the wound is progressing, that that extracellular matrix is remaining viable within the wound bed. And I think that photo there is a really good example of what residual endoform can look like. We can start when you're first applying endoform, you can apply 2 or even 3 layers of the product. Leave that in place for 3 to 7 days. We change it to 1 to 3 times a week, and then see what it looks like. And as I said, if you see no product when you do the next dressing change, you can step it up, add another layer, or increase the dressing change frequency. As opposed to if you're seeing a high amount of residual endoform, you can decrease the layers, or you can stretch out the dressing change frequency. As we know, undisturbed wound healing is our goal. And my goal for this product is to leave it in place a whole week, and eventually you open that up and it's closed. So there have been over 6 million applications of this product, very familiar with its clinical use and outcomes. Again, we have all of these extracellular matrix proteins within the product that are really important in healing. It's much more than just a collagen scaffold. We have those natural vascular channels within it, and you can just see them when you hold it up to the light. You can see all the blood vessels, the residual channels within the product. This is a case of mine of endoform natural. This was a necrotic hematoma of the leg, a 78-year-old female that presented to my clinic. She had moderately complicated past medical history of chronic kidney disease, AFib. So she was anticoagulated because of the atrial fibrillation. She also had a history of basal cell carcinoma and hyperlipidemia. So she developed this massive hematoma to her leg, and I evacuated the hematoma. This was the wound at presentation following debridement. And we can see this is over 100 square centimeters. So when I'm looking and I'm thinking, could I apply a cellular tissue product to this? Well, I can't buy a big enough product to cover the area that I need for this wound. In addition to that, no insurance coverage. She had no, we asked, they said no. So I'm thinking, what can I do for this patient? And she did heal in very well. She had a massive hematoma and she healed in for a while, but then she stalled. And I biopsied it. The biopsy came back completely normal, nothing suspicious happening, but she had this unusual attachment to the wound edges to her wound base. And her measurements at the time where it became stalled were still at 55 square centimeters. So we're still looking at a large size of a wound. Typically, anything above 12, and we can't be applying CTPs even if they're approved. So I began weekly applications with Endoform Natural. And as we can see at follow-up, we already have significant epithelialization noted. So we can see better attachment of the wound edges. We're not getting those recurrent openings of the neoepithelium where she had healed and then would keep opening up. Right now, the support of that extracellular matrix is helping her to epithelialize in. So noting this 39% area reduction after being stalled for quite a while, I'm thinking, if it's not broken, don't fix it. Let's continue the Endoform Natural and see what happens. And what we saw was continued attachment of that wound edge, continued migration of the epithelial edge with that weekly application of Endoform. And she was eventually healed. So this was a very successful use of the product. So again, here we can see a stalled wound despite advanced therapies, despite adequate wound bed preparation in the clinic. So this was really the product making a difference for the patient. Looking back on my use of Endoform, and why I like to use Endoform, this is available to every healthcare professional. So with delays in care, with patient wait times, we want patients to have access to things from day one. So this is something where a nurse can apply it the first time that they see the patient. They don't have to wait to see me, or if I don't have weekly spots available for grafts or on vacation or whatever happens, this is something where the patient is still getting that high quality extracellular matrix. They're still getting all of those proteins and molecules associated with that on a weekly recurrent basis. It's super easy to use. So it comes, it's shelf stable, it's not cryopreserved, it doesn't require a complicated preparation or ordering, and it has to be used within a certain couple days. This is very easy to use. You cut it to shape. It's okay if it overlaps. You can stack it. So very easy to use. Of course, it's successful. It can kickstart healing in acute and chronic wounds. So this is something where, I think the evidence really supports using this product, that it's much more than just collagen. You're getting a really high quality product for a very economical price. This is an early use treatment option. So this is something where I don't have to apply to insurance and wait and get denied and appeal it and have a one-on-one with a medical director. This is something where I can just start using it right away and get the results that I'm looking for. It's also something that can be used across the care continuum. So because this is so easy to use, it's versatile, it's affordable, this is something where even if the patient, because of transportation issues, or what have you, I can order this, start it in the clinic from day one and then order it for the home environment or order it for the facility environment if that's where they're going back to, and continue that care across the care continuum. Reflecting back on kind of my journey with using Endoform and thinking back, to the patient, the case that I shared with you about the leg, I'm thinking, I could have probably started using this much earlier for this patient and not having to wait for her to have become stalled. This is something where earlier use, may have helped prevent it from becoming stalled and expedited her healing process. So I look forward to using the product more in that fashion and hopefully, expediting outcomes, healing outcomes for my patients. If you'd like to learn more, they have a website here. We have aroa.com, customer service contacts for you. You can follow us on LinkedIn at Aroa. Thank you very much for joining me. Here we have some time for questions and answers.